very interesting session for the next couple of hours, hot debates in cataract surgery. And I'm sure when we look at the topics, we truly realize that these are so relevant to us in our day-to-day practice, and nothing short of the best speakers and the top-notch expert panel to adorn this 2-hour meeting. So let's look forward to good, crisp talks and a great exchange of thoughts and doubts. And I would look forward to everybody putting in their thoughts if time allows. We are truly, truly lucky to have with us our star of the day, Dr. Prema Padmanabhan. And it is such a loss that I lost her in my ARC meetings. Don't even ask me what or why it happened. And we all know she's heads the cornea department, but that she just head that. I think she's one of the main pillars of the Medical Research Foundation at Chennai, and we are indebted to you, Dr. Prema, and we look forward to learning great pearls of practical wisdom from you. Dr. Mohan Rajan would be joining us soon. We all know he's the chairman and medical director of the Rajan Eye Care, and also a past president of Tamil Nadu TNOA and IRSI. And he has there's some award session which is holding him up. We are really lucky, as always, to have with us a great stalwart of ophthalmology, Dr. Jeevan Titiyal, who is professor of ophthalmology of RP Center and heads it, and is doing probably the most wonderful, awesome job in his post now. And we wish him the very best in his career ahead. And we are really lucky to have you with us, sir. And we have with us Dr. Ramurthy, who's the chairman of the Eye Foundation group of hospitals and also our past president of AIOS. And I'm sure he will come out with his very practical viewpoints every now and then, and we would learn a lot from him. Joining us soon would be, hopefully, would be Dr. Namrata Sharma, who again is a professor of ophthalmology of RP Center and is also our awe-inspiring chairman scientific committee. And we look forward to wonderful work to be done by her in the coming 3 years. Introducing Dr. Meenu Mathan, who's again that magic luck for me in all my webinars in the last 3 years. And he's a senior consultant cataract and glaucoma services from the Chaitanya group of eye hospitals at Trivandrum, and is a surgeon of an amazing repute and has won innumerable awards, not just in the Indian ophthalmology, but at the international level. And I'm truly happy to have him with us as one solid expert panel. Joining us very soon is Dr. Gaurav Luthra, who's caught in traffic, who's again the director of the Drishti Eye Institute at Dehradun, and is another very versatile cataract refractive surgeon, and is also the chairman ARC of the IRSA group. So without ado, and of course, joining me a little haphazardly is going to be Dr. Kamal Arsi, who is a senior consultant at the Cataract and IOL services from the Eye Foundation group of hospitals, and a surgical trainer for all our young postgraduates, and an amazing surgeon. And we shall go on to there's going to be a little shuffling of talks, as both Dr. Jeevan Titiyal and Dr. Kamal Kapoor would have to leave shortly. So we shall start with that last session as the first to go. So this session is going to be an interesting session. The debate concept is, it's a 50-year-old with a clear lens and who wants spectacle independence. And we are looking at the different alternatives which would appeal to a person at this age group to get rid of his glasses. So we have two stalwarts of our Indian ophthalmology, the young Dr. Anurag Mishra and Dr. Kamal Kapoor, who are going to debate on this. And Anurag Mishra is a consultant, cataract, pediatric ophthalmology, squint and oculoplasty, name it, he seems to be doing it all, from the Karg Vision Eye Hospital, Orissa. And his topic is going to be clear lens extraction with trifocal, the right approach. And Dr. Kamal Kapoor, who is the director of the very dynamic group of hospitals, the Sharp Side group of hospitals based at Delhi, but which is spread out all over. His topic is going to be presbyopic phakic IOL could be the option. And moderating them and giving his expert view is going to be our expert panel, Dr. Jeevan Titiyal. So we would look forward to his thought process after the two have done their job. So, Dr. Anurag, we go on with your thought about clear lens extraction for a 50-year-old. On to you.
Thank you so much, ma'am. Am I audible and is my screen visible to all?
Yes, yes. Thanks for chipping in early.
Thank you so much, ma'am. Good evening, ladies and gentlemen, and greetings and regards from the land of Lord Jagannath. And the motion that has been given to me, the 50 years old presbyopic correction, a presbyopic patient who needs a correction, I think there is a little bit of incompleteness in this motion. And hence that's the reason why I've added on a few facets which have been clandestine in it. The 50 years old patient who has come to me for presbyopic correction has in all possibilities come to me for diffraction and glass prescription and not for a surgical choice. The moment I introduce him to the surgical choices that are available with me, and the discussion that goes on after that is basically because of the fact that the patient is intrigued more than motivated. And the motivation that needs to be curved into the patient has to be really crafted in. It needs to be curated into the patient. But hang on, is this the patient who needs to be motivated? Well, we'll see that at the end of the 6 minutes duration of deliberation that I have on my side. This story is going to be depicted to you, ladies and gentlemen, in its 3 stages, just like any story. The first stage is the prologue or the preoperative considerations. The main text is the procedural considerations, and then comes the postoperative considerations, which forms the epilogue. This is between 2 procedures which hang in the balance. One deals with disturbing the intact structures in the eye. There is no cataract and we're removing the lens like that. And the other procedure invades the intact space. So let's talk about a few changes that happen in this intact structures which are age-related, and how do they affect this intact so-called space that is going to be invaded by the phakic IOL. Let's talk about the crystalline lens first. Studies show that with increasing age, the axial curvature of the anterior-posterior diameter of the lens increases by 21%. This is one lens which is distant fixated of a young individual. The second picture is the near fixated lens of the same young individual. And the picture down below is the aged lens, which is distant fixated. So the anterior posterior diameter of the aging lens is even more, which is when it is distant fixated, than a young lens, which is near fixated with full accommodation in question. The result, the space with which the PIOL, phakic IOL is being utilized is going to be reduced. So it has more likelihood of brushing against or touching physically the lens and the iris both. There is a light scattering that happens in the aging lens, even without the presence of cataract. And the scattering happens most commonly in the C3 cortical area. The C3 cortical area is the innermost cortical area, which is closer not only to the optical center of the lens, but also to the nodal points. This is without cataract. Add to that the scattering or the reduced contrast that is likely to happen from a ring design of a phakic IOL. The patient's not going to have a very clear or crisp vision. The anterior chamber angle with age reduces to the extent of 0.11 mm per year. Now, to prove this is a patient of mine who's 50 years old. Look at the angle dimensions at 500. ACA 500 measures at 27 and 22 degrees. 27 and 22. Remember the numbers. This is another patient who is young and has come to me for ICL. The dimensions in the angle are 38 and 53 before surgery. Post-operatively, the same patient's angle comes down by 10 degrees to 29 degrees. So 27 and 22 in a 50 years old, that angle, if reduces by 10 degrees after you put in the phakic IOL, you are counting an angle of 17 degrees. Big reason to worry. Accommodation. At the age of 50, it is said that the accommodation is really absent, but some of them are left with a 0.5 diopter. So it had been difficult for us to decide the add power that we are giving to the phakic IOL. And if there is a 0.5 diopters of accommodation left, eventually it wears off. Eventually, the patient also has disturbances in his near vision. The spherical aberration, while we implant an intraocular lens, all we have to negate is the corneal spherical aberration, which is around 0.2. But when we are judging the phakic IOL, the total spherical aberration of the total eye as a system has to be taken into consideration. And this negative spherical aberration in the phakic IOL is not enough to negate all that. So the crispness of the vision might not be there, although you might have a good depth of focus. When you consider a trifocal IOL, which of these factors to consider? Practically none. But when you consider a phakic IOL, And which of these preoperative factors to be considered? Well, all of them. Let's go to the procedure part. These are the two IOLs that are in question, the trifocal and the presbyopic correcting phakic IOL. The refractive index has a difference, 1.46 and 1.55. The basic reason is the phakic IOL is hydrophilic in nature. And in that range, we all know that 1 point decimal difference between the refractive index also plays an important role. The ring design they have created it has less number of rings from 5 to 9. So that's a good job. I'll give it to them. But let's talk about the only study that has been published in here. The pupil diameter reduces after ICL or phakic IOL, and it does not recover even after 3 months. With a trifocal IOL, it also reduces, but it recovers after 3 weeks to 3 months. The reason, the difference between the two is the phakic IOL actually has a mechanical factor for which the the pupil size reduces. So consider a patient driving under mesopic conditions, the pupil is small, the distant vision is going to be affected, which does not happen with a trifocal IOL because there's no mechanical factor. This is the only study that I could find of note where they have studied 8 patients, 16 eyes, and look at the results.
Doctor,
4 weeks after surgery.
You have 1 minute, yeah.
9 out of 16 eyes are emetropic. 9 out of 16. What happens to the rest 7? We don't know. The 40 years old produces a very decent depth of focus curve, but at 48 years old, look at the intermediate vision dropping significantly. This is another curve from the same study, 20/20 or better after bilateral implantation with a phakic IOL goes up to 60%. It goes up to 80% in case of trifocal IOLs. So after surgery, different studies have shown different incidence of cataract formation after phakic IOL, 9.6 to 5.2, but they all agree that it happens. Dr. Mandal also thinks that there is a significant risk of glaucoma following phakic IOL implantation, and some of them actually go on to develop refractory glaucoma. So the conjure of all these factors combined, presbyopic PCIOL is the best choice for this patient, particularly when the bar ranges are less than 6 or more than 30, or if the cylindrical dioptric requirement is more than 3 diopters, because trifocal lenses are not manufactured in that level. But the CLE is a better option if you respect the age-related changes in the structures, pre-MD post-operative complications. Do not grin at the prospect of multiple phases of earning coming from the same reserve, and do not readily accept based on an anecdotal, fragmentary, and headed evidence rather than scientific one. So, ladies and gentlemen, the motivation that we were talking about in the initial part of the discussion was actually not needed by the patient. It's actually needed by this guy, and who better to provide the same motivation and curate into him than the person who is considered a master in that subject. With that, I must rest and give it to the next speaker to curate that motivation into me. Waiting for your 6 minutes to be over, sir. Thank you.